So without further ado, let's talk pulmonary ventilation. So this process is really simple and you do it every minute of your life. Literally, every second of your life, you inhale or exhale. Clear? To understand how it works, we need to introduce some physical parameters, pressures, and something that we need to remember all the time. Gases move from high to low pressure. Does that make sense? We can put it this way. So, higher pressure, lower pressure, gas movement. Okay? Does that make sense? Now, next picture will be grossly schematic. Don't take it as an actual anatomy. So, your lungs are within your pleural cavity. Are we clear? So here you have a respiratory passage. The blue is the lung. So lung, black is pleural. No, we're not going to write pleural cavity just yet. Now, this empty space, you see that empty space? There are two membranes over here. Check this out. So you have a membrane that goes along the surface of the lungs. Does anyone remember how we call a serous membrane that runs along the organ? Visceral. So this will be visceral pleura. Okay? Now, this layer over here that runs along the surface of the pleural cavity is called parietal pleura. Are we clear? Now, this is why I was hesitant to write pleural cavity. So this here, the space between visceral and parietal pleura is called a pleural cavity. We good? Now you should remember that serous membranes produce fluid, right? So this serous fluid lubricates the surfaces of visceral and parietal pleura, and it basically plays two roles. Listen, it reduces the surface tension. There's a surfactant in the serous secretions. Does that make sense? So that reduces surface tension and makes lungs more, so to say, inflatable. Okay? It also lubricates. If there is some kind of an infection affecting the pleura, so-called pleuritis, that results in accumulation of fluid in that cavity. Okay, and we're going to talk about pressures, we're going to talk about the outcomes of pleuritis. For now, let's talk about the pressures that guide the pulmonary ventilation, shall we? So, we're going to introduce several pressures that we're going to deal with. First of them is atmospheric, PATM. Where is atmospheric pressure? Outside the lungs. So this is why I placed it here. This is your atmospheric pressure. Am I clear? Now, let me ask you this. Oh, and there is a pressure within the lung. It's called intrapulmonary pressure. Are you following me? pressure within the lung. Now, there is some pressure within the pleural cavity, here. It's called intrapleural, PIP, intrapleural pressure. For now, does that make sense? Now look at this scale. First of all, see this? The gas movement thing? So here's my question. In order for the air, and now take these schematics almost literally, in order for the gas, for the air, to go from the atmosphere into the lung, what should be the relationship between the atmospheric pressure and intrapulmonary pressure? So during inspiration, what is the relationship between atmospheric pressure and intrapulmonary pressure?
Atmospheric is greater.
Yes, atmospheric pressure, absolutely right, is greater. And then, air can go this way. During expiration, the relationship will be inverse. We clear? Now, I have a quick question. Can we change atmospheric pressure? Normally, like now in this room, no. I mean, I can think of these scenarios, but realistically for proper breathing process, So here's the thing, listen up. When we inhale or exhale, the pressure that we manipulate, first and foremost, is intrapulmonary. Am I clear? Now, I'm going to give you some hint. Your lung is very elastic. Think about a balloon. When you inflate the balloon and you just let it go, balloon will collapse back. Does that make sense? Your lung even more elastic than a balloon. Clear? Now, I have a question. How do you think these two pressures relate to each other? Intrapulmonary and intrapleural. Remember that the balloon, which is your lung, is very elastic. Which one should be greater? And why? Go ahead. Come on, it's 50-50 choice. I know that you want to come up with a reason. Pressure within the lung versus pressure within the pleural cavity. Which one is greater?
Lung.
Of course, yes. Can you come up with explanation why?
Because if it wasn't bigger, it would just deflate.
Yes, exactly. Even if look, this is basically this is the basics of inflating a balloon. When you have a balloon and you don't inflate it, the pressure inside the balloon and the pressure outside of it are the same, right? In order to inflate it, you need to increase pressure inside. So in order for the lung to stay inflated, remember those lungs that we were working with? They were all collapsed. Those were big, honestly. Big lungs are large. I did, what's it called? It's not thoracotomy. I can't think from top of my head. It's called pneumatorex. So I opened up the chest of a mouse. At the end of the surgery, it was a standard procedure. Mouse was anesthetized. So I open up the chest, and immediately, and I open up, obviously, the pleural cavity. So the pressure within the pleural cavity becomes equal to the pressure within the lung. And mouse lungs, they look after that like leaflets, like tiny, they collapse immediately. Does that make sense? Okay. Now, there is so-called transplural pressure. So pressure difference between intrapleural and intrapulmonary. So definition of transpleural pressure is this. It's the intrapulmonary minus intrapleural. Intrapleural minus intrapulmonary here. See that? Now, since intrapulmonary pressure is higher than intrapleural, what's going to be the sign of transpulmonary pressure? It's going to be negative, right? It's going to be less than 0. And normally, in a physiologically healthy person, transpulmonary pressure, here, transpulmonary pressure, is by definition is less than 0, and it must be all the time. Are we clear? Does that make sense? Now, let's talk about the processes of inspiration versus expiration in the process of pulmonary ventilation. So, inspiration. Some of the stuff I'm not going to put on the board, some of the stuff I will. Okay? So, when we inspire, what happens to the size, volume of our chest, volume of our thoracic cavity? It increases, right? We expand thoracic cavity. Now, I forgot to mention there's a law called Boyle's law, and I should put it here. Kind of a premise. I'm going to ask you a stupid question now. Your thoracic cavity here, is it closed? Yeah, I don't see any holes in me, right? So it is closed. The thoracic cavity. I'm not talking about the lungs. I'm talking thoracic cavity. So Boyle's law states that in a closed system, physically closed system, the product of multiplication between the volume and the pressure at the constant temperature is constant. Now, what does that mean? What does that physical law mean? Look at this. Look at my hands. You have that volume with a certain pressure. That's P1, V1. Look at my hands now. Volume increases. As volume increases, what happens to the pressure? Decreases. You see what I'm saying? As the volume of the system goes up, the pressure within the system goes down, and vice versa. This is really important to understand how this whole system works. So, when thoracic volume increases, both pressures here, both intrapulmonary and intrapleural pressure, they go down, right? So, when intrapulmonary pressure becomes lower than atmospheric, air goes in. Clear? Now let me ask you this. Is this process active or passive? Meaning, do you make an effort to breathe? To inhale? Do you have to contract muscles to inhale? Yes. So, during normal or tidal respiration or tidal inspiration, the one that you do now, the main muscle that expands your thoracic cavity is diaphragm. Does that make sense? When diaphragm contracts, it descends and the volume of thoracic cavity expands. Now look what happens when I need to make a deeper inhalation. I engage my intercostal muscles, okay? And if I need to engage, like if I need to make a really, so those muscles are main muscles of respiration, your diaphragm and your intercostals. Are we clear? There are accessory respiratory muscles, like levator scapulae and scalenes, that allow you to expand your chest even more. Okay? So far, so good? Now, what happens during expiration? So, thoracic volume decreases, intrapleural and intrapulmonary pressure correspondingly increase. Intrapulmonary pressure becomes higher and atmospheric, and air goes out. Does that make sense so far? Go on.
If intrapleural pressure increases, does the pleural pressure in the lungs always increase? Like, do they always increase or decrease together?
Yes, because, well, again, I really like the comment that Dr. Nussbaum uses to preface all his explanations. When we talk about this stuff, we talk about normal, healthy, physiologically healthy subject.
Okay.
Yes. Now, think of it this way. To your question, imagine that intrapleural pressure rises due to the accumulation of fluid because of the inflammation. Remember what you told before? When if intrapleural pressure becomes equal to intrapulmonary, lung will collapse. Yes. So the difference, the transpulmonary pressure here, transpulmonary pressure is always negative. It can be slightly more negative. If it's more negative, if the difference is bigger, then the lung will expand. If difference decreases, lung will kind of not collapse, but deflate, so to say. So here's the question. Look, we already discussed that the process of inspiration is an active process that involves muscles, right? We're good so far? And process of expiration is the passive process. You can just, muscles being relaxed and just you exhale passive. So have you heard about the disease called polio? Probably have. So one of the, along with the paralysis to the legs, one of the pretty common consequences of polio is respiratory problems. You may have heard about the devices called iron lungs. There were thousands of them at some point in hospitals because I listened to numbers. Tens of thousands of children ended up being in iron lungs because of polio. But here's the thing. When they went through physical therapy and rehabilitation and stuff, this is what happens, and there were examples. There are still adults who live in the iron lung. But what does that mean? They live in the iron lung during the day. They move around without an iron lung, but they have to sleep in the iron lung, which essentially expands and collapses the chest for them. You see what I'm saying? They have to sleep in the iron lung. It's not an easy question. It's not very hard, but it's not an easy question. How can they go through the day without it, but have to sleep inside the iron lung during the night?
Conscious control.
Yes, you can consciously control your breathing. Does that make sense? So if my diaphragm is paralyzed, my intercostals are kind of half-assing, I still have my levator scapula and scalenes, right? So I can forcefully breathe during the day. I mean, it requires an effort, but I can do that. When I go to sleep, that's it, I can't. Because my partial unconsciousness, it's all just reflexes. See what I'm saying? So, and that was true for many patients with polio, that they would go through the day without it, but would have to sleep in one. Good? Now, let's figure out what happens in a couple of conditions, which I really like to talk about. One of them is called atelectasis. So imagine that somebody puts a plug, like a bottle stopper in your trachea. It completely blocks the incoming air. I'm not okay, let's make it less invasive. Let's not do the entire, because at this point you're dead. So let's say one of the lobar bronchi. Okay, let's say one of the lobar bronchi is completely blocked by mucus. Okay, so there's no air coming in. Air that is being in the lung, there's some absorption of gases by the blood. Does that make sense? So which means gases leave the lung, but they aren't coming in. So intrapulmonary pressure decreases. Are you with me? And when intrapulmonary pressure decreases to the moment when it's equal to intrapleural, what happens to the lung? It collapses. It deflates like a balloon deflates, like flat deflates. It's called lung collapse. That makes sense? Doesn't happen too often because it's got to be like a considerable amount of mucus. What happens more often is the term that I already used, pneumatorex. Now, in pneumatorex, the one that I described, I can tell you what I did with mice. Our protocol, basically, one of the key procedures we worked with mice and we did terminal surgery, which means at the end of the procedure, at the end of the experiment, it wasn't survivable surgery. Does that make sense? So the key question is, how are mice euthanized? How they are sacrificed at the end? Okay, are you following me? In our case, and usually you have to have two procedures. You have to have like a primary euthanization, and then you have to kind of confirm the kill, so to say. So our primary euthanization procedure was exsanguination, either through an artery, either through carotid artery. We sometimes had a tube inserted in the carotid artery, or through just heart. You put the needle in the left ventricle, which was not easy, finding a left ventricle in a mouse, but you stab them in the heart and you suck the blood out. Does that make sense? They anesthetized, don't get me wrong, they like painkillers and sleep medicine, so they don't feel a thing. But you take the blood away, that's it. But then you have to do a confirmatory procedure, which was pneumatorex. So what we did, we just cut through like rib cage, just opened the rib cage because we needed to harvest organs anyway. Okay, that makes sense? Now, in humans, usually if somebody opens human rib cage to harvest organs, collapsed lungs is not the main concern at this point. Pneumatorex in actual real life usually stems from a sharp object going through the thoracic wall, like this. Okay? See the hole here? Now, when I have a question actually. At the bottom of your exhalation, like look at me. Here at the bottom, there is no movement of gas, right? Between the air and my lungs. What is the relationship at the bottom of exhalation or at the top of inhalation? What is the relationship between atmospheric and pulmonary pressure when there is no net movement of gas? They equal, right? That makes sense. So at the bottom of my exhalation, pulmonary and atmospheric pressure are the same. Clear? When there's a hole, after some time, what's going to be the intrapleural pressure? It's going to be equal to atmospheric, right? It's going to be equal to atmospheric because air will just flow in. Am I clear? And once here's atmospheric, check this out. Here's atmospheric. Here's atmospheric. What's going to happen to the lung? It's going to collapse. That makes sense? So this is something that you, as health professionals, may likely witness, especially if you work in places like emergency department. People with like wounds or traumas after car accidents. Okay? That makes sense? Clear? So, how do you fix it? Anyone knows? So, you need to suck the air back out of pleural cavity. Okay? So basically you need to patch up. The easiest, like the most primitive way, is to patch it up and then stick the needle, relatively thin needle, through the chest into the pleural cavity and suck the air out. You may ask, wait a minute, like poking another hole, right? Well, not every hole will result in pneumatorex. If you will take a syringe and carefully stick it through my chest into my pleural cavity and then pull it out, chances are I am not going to develop pneumatorex. You know why? Because my tissue will expand and it will close the hole. We're talking like a hole. So by using needle, it's pretty safe. Does that make sense, this story about the pulmonary ventilation and the chest, like all these processes? Okay. Awesome.